So, controversies in spine MRI. I'd like to talk about nomenclature for MR findings, which really come from the North American Spine Society classification. What I'm not going to talk about are areas that really have very little controversy, including severe acute trauma, infections, congenital lesions, and neoplasia. Plasia I will not really discuss in this talk. I will talk about MRI correlations with clinical findings and outcomes in back pain, and maybe some new horizons if we have time today. If we get to new horizons, I do have a conflict of interest in that I'm a medical advisor to NOCIMED, which is involved with commercialization of MR spine disc spectroscopy.
Dr. Cruz, I don't see this.
What?
I don't see this presentation. Is the presentation on?
Uh-oh. Uh-oh. I don't think you missed too much not seeing those. So back in 1991, the cost in the U.S. for treatment of back diseases was over $100 billion, and now it's much, much higher than that. So it's a big ticket item in the U.S. A study out of JAMA really caused a lot of stir and medical economics. And this study, published in 2008, showed that if you take Medicare statistics from 1997 to 2005, Medicare patients who had spine complaints were much more expensive. They're the upper, the solid points here, and those Medicare patients without spine disease are the lower is the lower line here. You can see what the actual numbers are, but so patients with back pain cost almost a third more per patient to Medicare than Medicare patients that did not have back symptoms. Furthermore, they looked at outcomes in 1997 and outcomes in 2005, and a higher number is bad. It means more functional limitations. And in this follow-up study, they found that at the end of the study in 2005, despite the increased costs, the patients were actually doing worse than they were in 1997. So the conclusion of this particular paper is that spine problems may offer opportunities to reduce expenditures without associated worsening of clinical outcomes. And in reality, what Medicare and insurance companies have decided is that this actually leads to poorer outcomes, and therefore they put a lot of effort into trying to decrease interventional rates in spine diseases. There have been a lot of articles in the lay press. This is one from the LA Times, kind of scaring people into worrying about interventional procedures and spine diseases. Some other studies that came out before that is a study in spine that showed that high rates of MRI correlate with high rates of interventional procedures of the spine, especially surgery. And then if you actually look at patients who initially were evaluated by MRI versus X-ray when they came in with spine problems, they found that having X-ray led to higher surgery rates, but no better outcomes at the end of 1 year. So they were suggesting that expensive imaging may not be cost effective when it comes to spine disease. And this led to utilization review and actually companies that have started up after that, whose sole purpose is to work with insurance companies and managed care patients to put in procedures to decrease the utilization of MRI. They're less concerned about limiting the cost of MRI. They're much more concerned about limiting the cost of the interventional procedures because they are much bigger much bigger ticket item. So those are the headwinds that we're working with right now. I'd like to drop back and talk a little bit about some of the findings that we see on MR examination of the spine and what their significance are. And then I'd like to talk about some clinical studies which have used MRI findings in evaluating patients. So this comes from the NAS, North American Spine Society, where they talk about different classifications of spine disease. We're going to talk primarily about degenerative disease because that's the area that's most controversial. There are many etiologies of back pain, which everybody's familiar with, from bones to joints to discs to nerves and soft tissues. And I'm going to talk mostly about discs, but I'll talk about some of these other issues as we go along as well. Now, one thing that we kind of need to start with is a little bit of epidemiology, and that is, when does this start? Well, this was a Swedish study first described in 2011, which showed that by age 8, 9% of people in their study in Sweden had at least one complaint of significant back pain. By age 19, over 50% of the people sampled in this study had complaints of back pain. 14% by age 19 were severe enough to warrant medical consultation and evaluation. Also, if you do MRI scans on these individuals, 15% of 19-year-olds showed desiccation or decreased water within one disc, and we'll talk about signal changes within the disc a little bit later. Furthermore, 60% of 19-year-olds showed at least one abnormality on an MR examination. So this is a disease that starts in the teens. And we've got to realize that a lot of the findings that we'll see on MR, as we'll see in a minute, may not correlate with significance findings. So let's talk about the different findings. So we're going to talk about the signal intensity within the disc herniations, the location of the herniation, size, nerve compression, and what we look for in postoperative evaluation of disease. So let's start with nuclear signal intensity. There have been several studies. This is a pathology in cadavers. This is the signal intensity on the right, where you can see the normal is nice and high in signal intensity, and then you can get progressive decrease in the height and decrease in the signal intensity as the degenerative process occurs within discs. Now, what is the significance of the MR signal intensity? This was a study where they correlated, and there have been a number of these, but this is probably the best one out there, where they correlated discographic findings with MR changes. And what they found is positive discography is uncommon in discs with normal signal. So it does not pay to do discography in those individuals. Positive discography is common in patients with moderate signal loss. And then positive discography is very common in people with severe signal loss. But the outcome of this study, they suggest that MRI signal in and of itself is of limited value in determining the source of pain and if the patient needs surgery, which disc to operate on. That discography is most useful in evaluating those discs that have moderate signal loss, not normal discs, and not those that are severely degenerated. So this was their recommendations. Karagi up at Stanford did a study published in Spine in 2009 where they looked at discography. They had 50 patients with 52 matched control that underwent MRI and discography in 1997. After 10 years of follow-up, they did a repeat MR, and what they found is the findings that were statistically significant is that in the discs that actually had discography, there was increased degenerative changes compared to the control. And what they found in the disc that had discography was a decrease in height and a decrease in signal to loss over the control. Secondly, they found that there was an increased incidence of new disc herniations in those discs that had discography on the site of the puncture. So basically, their conclusion was that discography does do damage to the disc and that there's a need for non-invasive replacement for discography. And at the end, if we have time to do New Horizons, we can talk about potential replacements for discography. So that's nuclear signal. Let's go on to nomenclature and herniations, because this is an area that's been very confusing. Normal disc, a little bit of an annular tear or annular fissure by the NAS criteria, and then a herniated disc. Everybody's familiar with. This is a patient on 3/9/2009 that showed a little bit of a disc bulge, minor signal loss, and maybe a little bit of loss in height. And we can see a very minimal little protrusion in the subarticular zone on the left side. This patient was followed, had a little bit of increased pain. Here on 4407, we can see several changes. One, he now has increased signal intensity within the annulus, called a high intensity zone or an annular fissure. And we can see that there's increased degenerative disease with signal loss and disc height loss. So this was a new development of a fissure in someone who had some symptoms. We don't know that it's actually referred to that disc or not. But there have been, and initially when this was described, people thought it was pathognomonic of a painful disc. However, more recent, larger studies have shown that annular fissures are generally stable lesions that do not progress over time. So most of these are chronic, they're granulation tissue, and they're really a signature of degenerative annular disease, and that they're rarely associated with symptoms. Paper by Jeff Ross and also by Munter. The North American Spine Society, in talking about the morphology of disc herniations, They describe a generalized bulge, which means that more than 180 degrees of the circumference of the disc extends beyond the bone, or localized, where it's less than 180 degrees. Of those that are localized, they divide them into broad base, which are between 90 and 180 degrees, and focal, which are less than 90 degrees. The concept being that focal may more likely be associated with symptoms and trauma. The focal protrusions can also be further divided into protrusions, which they have their definition of here, but which simply means that it's wider than it is deep. And this is just an example of a protrusion. We can see the disc protruding beyond the margins of the bone. And here, if you look at it, this is less than 90 degrees, so it's focal, but the width here is greater than the depth, so this is a protrusion. And then an extrusion is deeper than it is wide, extends out, typically up and down a little bit in the spine. And here we can see an extruded disc where the superior and inferior height is greater than the opening through which it went through in the annulus, and we can see the depth of the protrusion, the extrusion here is larger than the width. So this is an extruded disc. And there is at least one study that suggests that these may more likely be symptomatic than protrusions, but we'll talk about that data in a minute. The other thing that you can look for is migration of the disc away from the area where it herniates from, and this just shows superior migration of a large extrusion superiorly along the L2 vertebral body. Sequestration is when the disc no longer is, the extrusion is no longer connected to its disc of source disc, and we can see a typical sequestered disc here, and this is what it looks like on an MR examination. So here's disc material which is separated from the disc of origin. And this is a 26-year-old professional hockey player who had right L5 radiculopathy. We can see a protrusion, extrusion, a little bit of migration inferiorly here from L4-5. This is what the extrusion looks like on the axial images. This was on 11/23/09. He had persistent pain, continued to play, and here we can see the sequestered fragment which developed from that extruded disc on 12/14/09. He actually went on to surgery and then had some complications. Here we can see. And that became sequestered. So that's the basic nomenclature that's recommended to use for talking about disc herniations. The other thing that's important is localization, and we'll see later why this is maybe significant for symptoms. And that's typically, if you look on the axial images, the midline is considered the central canal zone. The subarticular zone is to the lateral side on either side of the central zone. Then in the region of the foramina, there's the foraminal zone, and then there's the extraforaminal or far lateral zone. And as we'll see in a minute, the foraminal zone protrusions may be indicators of possible symptoms. And this just shows a central and subarticular zone protrusion on a 3T scanner, or extrusion, excuse me. Here we can see an extruded disc going into the left L4 foramen. We can see it superiorly displaces the nerve root there and compresses the nerve root. On the axial images, we can see a swollen nerve root out here. And then you can see a lateral disc extrusion here. One thing I'd like to comment on is that contrast enhancement, this patient did not have surgery. Contrast enhancement is common in people who do not have surgery because all focal disc herniations can induce a inflammatory reaction or a fibrous reaction around them, which will enhance with contrast.
For how long? How long will it?
I'm not sure. Probably years.
Oh.
And then here's just the axial plane that shows this as well.
What does it mean you said the annular things are excluded? Don't use that?
Annular what things?
In your nomenclature, you said annular, exclude annular bulges, I believe it said. Because we talked about extrusions and protrusions. What about?
I don't know what you mean.
It was
We'll come back to that later, and then we can see. Okay, the other thing to evaluate is the size, and the North American Spine Society suggests that people look at the cross-section area of the canal and determine whether it's less than a third. I find this not very useful. So most people I know actually give the size of the disc extrusion or protrusion itself, though as we'll see in a minute, there's some that may not be very helpful from a medical standpoint either. And then to evaluate for nerve compression, which was kind of in the past is thought to be kind of a sine qua non of why disc produces symptoms. Here we can see a little bit of decreased fat surrounding the L4 nerve root in this location. And here we can see the extruded disc here and some swelling of the nerve root. We saw this before with a little bit of edema. And there's conflicting evidence as to whether this is associated with radiculopathy or not, and we'll get to that in a minute. The other thing that people have looked for are enhancement of nerve roots. Here we can see an enhancing nerve root along the course of the nerve root, and there's suggestions that this may be associated with symptoms, but that really hasn't panned out to be a reliable indication of symptoms either. And here we can see a swollen nerve root with enhancement. So that's just some basic nomenclature of what to look for when we're looking for a disc disease as a cause of back pain or radiculopathy. Now, what are the correlations in the literature between MR findings and clinical findings and outcomes? This was a study from Hopkins where they looked at non-disc contour degenerative changes. In other words, not protrusion or extrusions, but they looked at spondylolisthesis, disc degeneration, end plate changes, whether we have fissures or high intensity zones, and facet arthropathy. They just set a spondylolisthesis, so it was any displacement greater than 1 millimeter. They used the system that I showed earlier concerning loss of signal intensity and height within the disc, and graded the disc on 1 through 4, which came originally from Furman in Europe. They looked at end plate changes using Mike Modit's classical 1, 2, and 3. And they looked at areas of high intensity zones in the posterior annulus, and facet arthritis, where they graded it as normal, mild, moderate, or severe. And when they took all this together and had experts around the country evaluate the MRs, is what they found is that there was not very good agreement between MRs on any of those findings. You can see what the kappa numbers are. So they raised the question as to whether or not these are reliable findings, since there's not good agreement between experts on how to grade them. And the other thing is disc protrusion and extrusions. And here we can see that there is a central focal protrusion at this L5S1 level on 12202. Patient had no surgery. There was a follow-up on 111302, and we can see it markedly decreased in size. And there have been a number of studies now that have looked at acute disc herniations and followed them without surgery, and the vast majority are resorbed within 9 months to a year. And these are those studies. And this is important because it suggests the reason why the Mike Modic's findings in this particular patient study are the way they are. So what clinical associations do we have with disc protrusions? And there are many studies that have looked at this now. One is that disc protrusions are common in patients without symptoms, and that there's no statistical correlation between the presence of a disc herniation and whether or not that patient has pain. What MRI findings correlate with prognosis in patients with low back pain and sciatica? These are 2 studies by Mike Modic in Radiology. What he found is that the herniation type, whether there's a protrusion or extrusion, the size, location, and changes over time do not correlate with clinical outcome, with one exception. Anybody want to guess what the exception might be? Yeah, those are all good ideas. Those actually, and I'll come back to the disc material on the nerve later. The location by their studies didn't really matter whether it was by the nerve or not. What they found, however, is if it was an acute disc herniation, patients had a much better prognosis than if they did not have a disc herniation. And the reason is that if you have a disc herniation, an acute disc herniation, it's going to be resolved within 9 months to a year like we saw before, and therefore it's going to get better. Whereas all the other changes of disc that can cause disc pain don't get better. They tend to get progressively worse. So what MRI findings are seen in patients with new onset of serious low back pain? This is a study by Karaji from Stanford. He took 200 asymptomatic individuals with MRI, and he followed them for 5 years. Actually, they're not patients, they're individuals. And he found that 51 of these ended up with severe acute back pain. But when they redid the MRs, 49 of those 51 patients who had severe back pain had absolutely no changes in their MRI. 2 patients actually showed new MRI findings, which correlated with their symptoms. And both of these were foraminal-zone protrusions that were compressing the nerve root. So this suggested that hallowed finding that we thought was important for a long time actually is a significant finding. Therefore, foraminal-zone protrusions may correlate with patient symptoms, according to this study. Conclusions are that most MRI findings are not associated with the cause of back pain, except for acute foraminal protrusions. Protrusions elsewhere in multiple studies now don't correlate with back pain. Risk for serious low back pain is not increased by minor trauma, in particular automobile accidents and people who do not develop fractures does not increase the patient's risk for back pain. Serious pain, however, is associated with the setting of chronic pain, abnormal psychometric profile, smoking, and disputed compensation claims, but many studies have shown that to be the case in the past. So actually, these social factors are much more important than any of the imaging findings.
You want us to tell you if there's a mistake?
Yes. Do you see a mistake?
Okay. Most MRI findings are not associated.
Oh, thank you. And we'll get back to the other stuff. I just want to time this as the reason why I don't want to take too many questions right now. Thank you. Now, so Karaji did another study then. He looked what discography, MRI, and psychosocial findings correlate with disability and remission in patients with back pain. Of MRI findings, only severe end-plate changes weakly correlated with poor outcomes. Disc herniations, disc excrusions did not correlate with poor outcomes. Discography findings of all sorts had no correlation with outcomes in patients. Psychometric profiles of baseline, heavy labor occupation, and chronic non-lumbar pain correlated highly with poor outcomes. So now let's go on to what we look for in MRI after having surgery, postoperative MRI. So a number of things that people look for. They look for muscle denervation, muscle atrophy, recurrent herniations, scar formation, displaced or broken prostheses, infections, and other surgical complications. Here's a 36-year-old male with back pain. This is on 9/8/09. And what we can see here is that the muscles are very symmetric on both sides. So this is 9/8/09. The patient then went on to have surgery on 7/13/2010. And about 2 months after surgery, what we can see is asymmetry in the appearance of the spinal muscles. This is acute denervation of the muscles due to severing of the nerve at the time of surgery. Here's another patient, 29-year-old male with low back pain radiating down the left leg. Here we can see a little bit of desiccation of the L5-S1 disc, a very small little annular fissure there, maybe a little bulge at 4/5, a little questionable there. This is on 10/15/04. And here we can see at the 5/1 level, there may be a little tiny disc protrusion into the foraminal zone on the left side. This patient went on to, and we can see that there's nice symmetry of the muscles in the back here. He went on to 2-level discectomy and cage placement, which we can see here. Postoperative changes back there on the back. Here's at 5/1 level, and notice extensive atrophy of the muscles with scar tissue and fat replacement of the muscles at the 4/5 level. And at the 5/1 level, and at the 4/5 level, we can see the same thing. Extensive atrophy of the muscles in this location. So why is this important? Well, there are a number of studies now that show that the other finding on MR that correlates with symptoms has to do is muscle atrophy and increased fat within the muscles of the back. And this is by Mingardi, Bircher, and a recent one by Fischer show that this is that patients with increased atrophy and increased fat within the spina erecta muscle statistically are more likely to have back pain than people who do not have it. And the muscles are probably very important for stabilizing the spine during activity. and therefore you get increased microtrauma and instability if the muscles do not have proper strength and stamina. What other things do we look for? Here's a 40-year-old female with pain radiating to both legs for 3 months. We can see a focal extrusion here at the 5-1 level. This is on 3/27/2009. And there you can see the extrusion going into the foraminal zone. And here the patient went and had surgery, and we can see now a lot of replacement of the normal signal intensity there with scar tissue and metal artifact. And here on the axial images, we can see that there's extensive scar tissue engulfing the L5 and the sacral roots on that particular side. So for years, we've thought that this correlated with patient symptoms. In fact, in Mike Modick's really early papers in the 1980s, this was an important finding that he suggested that you really needed to use contrast to evaluate this accurately. And that time thinking that these patients should not have recurrent surgery because it would just increase the scar formation. However, in a recent paper from the New England Journal of Medicine just last week, is that they looked at a large number of patients who had MR scans done 1 year after their surgery. And it's what they found is that post-op scar does not differentiate between patients with favorable and unfavorable outcomes. And this is really the first good study, I think, that I know of that really looked at the importance of scar formation, and they said that it didn't differentiate outcomes. The other thing that we look for are disc extrusions. It's a patient who had surgery and then re-extruded the disc in that particular area with a little bit of displacement of the disc. So this paper from New England Journal of Medicine, what did it say about other findings that we've been talking about? Well, what they found is MRI findings of disc herniations, nerve root compression, herniation size, herniation morphology, and perineural scar at 1 year after surgery did not differentiate patients who had favorable versus those who had unfavorable outcomes. So these findings are not as valuable as we thought they were in the past. Other things to look for, here we can see disruption of the normal course of the nerve roots in the spinal area, and these are adhesions due to scar formation postoperatively. Another thing to look for, here we can see on the scout view of a patient with MR, it looks like the metal artifact from the cages are not really centered on the disc. Looks like it's sticking out here. And on the axial images, we can see a displaced cage, and the CT scan shows the same thing. Complications. Now, the other question is the use of MR in evaluating patients for radiculopathy. This was a study where patients who came in with 6 to 8 weeks of severe incapacitating radiculopathy all had MR examination, and then they were randomly assigned to either surgery or no surgery. And what they found is that those who went to surgery had faster pain relief, but after 1 year, there was no difference between the two groups. So all these questions really kind of beg the question, why use MRI? Certainly the roles of MRI in degenerative disc disease are important to map out structural changes before surgery. If they do have severe enough symptoms that they do warrant surgery, then you really need to have a map so that you know what you find when you go in there. Also to exclude non-structural changes before surgery, make sure that there isn't an infection or a tumor or some other cause of the patient's pain, and also to evaluate non-disc related disease in high-risk patients. So when should MR be used? This is really one of the earlier papers. This was in JBJS from Bowden, a classic paper in 1996, and their recommendations were in the setting of acute back pain that there should be no imaging in the first 6 weeks, unless there's progressive neurologic findings, constitutional symptoms to suggest infection, trauma, or known malignancy. And if you have chronic low back pain, MRI is the best study to evaluate it. In patients who have acute radiculopathy, again, no imaging in the first 6 weeks. The vast majority of people will get better with conservative treatment in that time frame, unless they have progressive neurologic findings, loss of bowel or bladder function, trauma, malignancy, or infection. Other groups have come out with recommendations. These are the American College of Radiology criteria for advanced imaging, and it's very similar to the Bowden study. They just describe some high-risk areas like cancer and IV drug abuse. But again, the duration to wait is greater than 6 weeks before doing studying, though they suggest imaging elderly patients over the age of 70 earlier than 6 weeks because a high percentage of those may have malignancy. And then the American College of Physicians came out also with recommendations for using spine imaging. One, they said that routine imaging leads to unnecessary interventions and costs, which basically came out of the JAMA article. Imaging criteria, they say severe or progressive neurologic deficits, suspected infection, cancer or severe trauma, and repeat imaging should just be based upon new and worsening symptoms. So a lot of the data is a little bit counterintuitive that's come out, but it really leads us to there are very few things on an MR scan that actually correlate with back pain and radiculopathy. One are foraminal-zone protrusions, which does seem to correlate with radiculopathy, though there's not every study has shown that to be the case. The other thing is fatty atrophy of the spinae erecti muscles tends to statistically correlate with people who are symptomatic versus those who aren't symptomatic for reasons we just discussed. So what else can we do if the actual evaluation of the disc by MR doesn't really correlate with clinically useful information? There are some additional studies that are being looked at right now. One is magnetic resonance spectroscopy, which I'd like to talk about, where we really measure lactate and other anaerobic metabolites. Look for T1 row, which is a technique on MR where we can evaluate the glucosaminoglycan concentration within the discs. The glucosaminoglycan concentration, if it's normally high, is a potent inhibitor of nerves growing into the disc. So for as long as you have normally high levels of glucosaminoglycan, the disc is a neural structure and therefore is unlikely to cause pain. Once, however, you start getting degenerative disease and loss of the glucosaminoglycan, there is nerves as well as vessels start invading into the disc, and therefore the disc can become symptomatic. The other thing that can be used is sodium imaging. It's not standard. It's really for research purposes only, but it's also a way to estimate the glucosaminoglycan concentration within disc. And some people have suggested the use of MRI tracers to look at diffusion rates into the disc, but that's very difficult. And it turns out that to do that, you have to image about 10 hours later because it takes about 10 hours for significant solutes to diffuse into the disc. And that's really not very practical. So the main measure we have then is MR spectroscopy. And the idea behind this is disc degeneration and discogenic low back pain is really caused by structural changes which actually lead to abnormal biochemistry within the disc. And the biochemistry is the loss of proteoglycans, and painful discs seems to be associated with cellular processes of hypoxia, cytokine production, neovascularity, and neointervention. And the interesting thing about this is that there are studies now that have been done in animals to suggest if you get these changes, there is gene therapy that may be able to reverse some of them and improve the symptoms in animal models. And this is just a recent study that came out of special surgery in New York looking at that, and I think it was in rats. So how can we do this with MR? MR spectroscopy is actually a technique that's been used in biochemistry for many, many years. It's really probably the single most important tool in the biochemist's armamentarium. What it does is it measures the amount of energy that's absorbed from RF pulses in spectroscopy at different frequencies. And different molecules have a specific signature where they absorb energy. And therefore you can measure the actual composition, the actual concentration of different biochemicals in tissues non-invasively by using a magnetic resonance spectroscopy. And this just shows a typical normal disc. This is a proteoglycan peak here. This is the lactate peak, and the proteoglycan peak should be higher than the lactate peak. If that's reversed, where the proteoglycan peak is small, the lactate is high, that correlates with anaerobic metabolism, and hypoxia within that area. And a study done at UCSF published in 2008 shows that there's a very clear separation between painful discs and non-painful discs when you get a reversal of that ratio. Normally, proteoglycan should be higher than lactate. More recently, Nosamed, which is the company I've worked with, has a commercialization of this process where you can see the discs here. This is when in a volunteer, not a volunteer for the study, but was a patient. The patient has MR scan. Notice that all the discs are relatively normal with just a little bit of signal loss at L5, S1. This is non-specific, as we've talked about before. Patient had discography at these two levels. This was a negative discography. This was a positive discography. And if you look independently at the MR data, the MR spectroscopy at the 3-4 level had a normal ratio. At 4-5 had a normal ratio, but we had an inverted ratio at 5-1. So this would be anaerobic metabolism as measured by the lactate peak on an MR study. And more recent studies using 3T systems with this algorithm has shown there's really been only one painful disc that fell into the non-painful area. There's really almost complete separation between the painful and the non-painful disc based upon discography. This is a non-invasive technique. It takes only a few minutes to do, and it's not painful. They just lie in the scanner and the study, and eventually it can be automated, so it should only add eventually 5 to 10 minutes to the MR study. Right now it takes about 30 to 40 minutes because it's basically a manual technique. So, controversies of the spine. We've talked about nomenclature for MR findings of the spine. We've talked about MR correlations with clinical findings and found those to be disappointing based upon what we've assumed for many years. But there are some new horizons, and in particular, non-invasive disc chemistry in the future may help us better differentiate where pain is coming from in the spine. Okay. All right. Any questions here?
Something where somebody's going to say, well, you've already said that MR correlations with